TopMedTalk.
Welcome to TopMedTalk. Today's programme is a look back at the fascinating development of the HPI Monitor. HPI stands for Hypotension Prediction Index. It's a first-of-its-kind technology that provides you with information regarding the likelihood of a patient trending towards a hypotensive event. We've tracked the development of this technology over the years here on TopMedTalk, and today we're providing you with a chance to understand the story using unique access and audio gathered by us over the last few years. So, hypertension, what's the problem? Well, we start with a clip which was part of one of the very first broadcasts our team ever did here on TopMedTalk. It's a clip featuring Dr. Dan Sessler from the Cleveland Clinic, one of the most famous and impactful investigators in the world of perioperative medicine, sitting alongside our Editor-in-Chief, Monty Mython, and Tim Miller, Associate Professor of Anesthesiology from Duke University Medical Center.
Anesthesiologists have always managed blood pressure, but we never really knew at what level to manage it. And a reasonable question, of course, is why after 160 years of anesthesia, we don't know this already. There actually is a good answer, which is that you need big data. This is not something you can do anecdotally, and it's not something you can do in a few hundred patients. You need tens of thousands of accurate, minute-by-minute blood pressure recordings to do this sort of analysis. We've now looked at hypotension under a variety of circumstances in the operating room, in ICUs, on surgical wards, and what we find is that moderate levels of hypotension for short periods of time are very strongly associated with myocardial injury, acute kidney injury, and death.
So we heard, again, we're very shocked by this. So as little as 1 minute. Is that right? The association is there for as little as 1 minute.
By the time you get to a mean arterial pressure of 50 millimeters of mercury, 50 millimeters of mercury during surgery, it takes 1 minute to significantly increase risk. Now understand, this doesn't mean that everybody who gets to 50 has a myocardial infarction or dies. What I'm saying is that it increases risk by a statistically significant amount.
So Tim Miller, were you shocked by that?
I think I appreciated that hypotension caused harm, but was I shocked by the fact that 1 minute caused a statistically significant increase in harm? Yes. Was I also shocked by the fact that a third of these events occurred between induction and incision, so were purely influenced by anesthesia? I think that's the second yes.
So influenced by anesthesia, can we be clear on that? I know it's happening in that window, but Dan, where do we stand on whether or not that is iatrogenic, created by us, or whether it's just a patient abnormality that we have not given enough attention to?
Okay, the distinction is important because sicker patients are more likely to get hypotensive, sicker patients are more likely to have bad outcomes. The hypotension may simply be an indicator of sickness. Fortunately, there was just a study published by Emmanuel Fouté, and this was a randomized trial of intraoperative blood pressure management, and what it shows is that tightly managing blood pressure reduces the risk of a composite of serious complications by 25%. 25% is a lot. That's a big deal. And it indicates that at least a fraction of this association is causally related, and by that I mean that intervening prevents the outcome.
Worrying news. Later in the studio, the TopMedTalk team gave further reaction, this time joined also by Dr. Geoff Lacey, an occasional presenter here on TopMedTalk, as well as being a consultant anaesthetist at St George's Hospital in southwest London, and John A. Kellum, tenured professor, critical care medicine from the University of Pittsburgh.
Thing that was concentrated on as well in this presentation from Dr. Sessler this morning with his large data sets from the Cleveland Clinic that have been published, it seemed to be that intraoperatively, during major surgery, a mean arterial pressure of less than 65 millimeters of mercury for as little as 1 minute is associated with serious adverse events. And the deeper and the longer that goes on, the more serious it gets. And I was hearing about heart attacks, I was hearing about kidney failure, and I was hearing about risk of death. Did I pick that up correctly?
Yeah, I think I was. I wasn't necessarily shocked by the statement that intraoperative hypertension may influence postoperative outcome. I think it was the brevity of that insult that is required to produce that outcome. I mean, as you mentioned, 1 minute with a blood pressure less than a mean arterial blood pressure of less than 65, and the risk of myocardial infarction in the postoperative period is significantly increased. In one sense, it was it was very informative for everyday practice. He mentioned that the relative threshold of a 30% drop from your preoperative blood pressure is not of increased utility than using the absolute threshold map of 65, and that makes it, I think, reasonably easy for the clinician to follow. But the significance of it was really quite impressive.
I think we have to be clear that this is an association, that frail patients are more likely to drop their blood pressure, and obviously being hypotensive is associated with adverse outcomes. That being said, I do think that personally, and maybe speaking for others, this is practice changing, that as we have this association, current evidence seems to suggest that we should do everything we can to avoid dropping the mean arterial blood pressure less than 65 for even short periods of time. And one particularly interesting stat that Dan mentioned was that a third of these hypotensive events occur between induction and incision. So this is not caused by the surgeon. This is directly a result, at least in a third, of anesthesia. And we all know this period is a dangerous time for hypotension. And I think it was fascinating that it was highlighted that as much of a third of the events occur during this time.
But as you said, we have to be very, very clear that these are associations. John Kellam, what did you take from all of those discussions?
Well, I think Tim not only said we need to be clear, but I think he also said we need to be careful. And I think caution is important. Hence, we don't repeat some of the mistakes of the past. I mean, I think we were very enamored by the notion of using beta blockers a few years ago to prevent adverse events in our surgical population. It seemed to make sense. It appealed to us at a variety of levels. And therefore, I caution us to be clear about the risks of therapy, and unintended consequences are also there. And so, to my mind, these potential interventions fall into three categories. I think that, and we touched on those, but just to characterize them, I think that there are things we can do that potentially prevent the development of iatrogenic hypotension, and surely that's a low-hanging fruit, as we might say, to work from. Surely we shouldn't cause intraoperative hypotension if we can avoid it. I think the second is treatment of intraoperative hypotension, and that gets to be a little bit of a slippery slope because of those unintended consequences. And then the third that we often forget about is that apart from anything else, the association is the association. Therefore, a patient who does develop an episode of hypotension intraoperatively is at increased risk. There's no argument there. It doesn't matter whether it's causal or not. It doesn't matter if it's a mediator or a marker. It's still something we can use to personalize the care that the patient receives after the surgery.
So I'll tell you what I've taken away from all the chats is that my tendency would be to treat intraoperative hypotension anyway. But perhaps I've become a little slower over the years with people believing it was less important in reacting to those, subtle drops in the first 10, 20 minutes where I used to be when I was a youngster, and I'm treating it straight away now. I don't. Is that a pragmatic, sensible? I'm not doing anything different to what I would have done. I'm just going to do it quicker.
I couldn't agree more, and I think, as John mentioned, there's other simple interventions that we can do, making sure that patients do stop their ACE inhibitors or their ARBs the day before, making sure that patients well hydrated when they get to the operating room, which we're increasingly doing, but occasionally this doesn't happen, particularly in emergency surgery patients. So there are a number of simple interventions, and of course how we actually induce anesthesia. We used to do a lot more gas inductions, for instance, which I think are hemodynamically less deranging than pushing propofol, and maybe that should be something that we should be doing more often in these high-risk patients.
But what we don't want is everyone giving vasopressors to treat all hypotension, do we? I think that's what, we don't know the answer to that yet. To be fair, we don't know the answer to any of it. But perhaps what you were planning to do anyway, a little bit more quickly, would be a pragmatic approach.
This next conversation features Monty Mython and Desiree Chappell with Andrew Shaw, Chairman of the Department of Anaesthesiology and Pain Medicine at the University of Alberta, Edmonton. Alberta and Zone Clinical Department Head for Anaesthesia, Alberta Health Services, Edmonton Zone. He's also a Fellow of the Royal College of Anaesthetists and the American College of Critical Care Medicine and the Faculty of Intensive Care Medicine. Have a listen to what he had to say.
Now, we published a series in the British Journal of Anaesthesia earlier this year, which was about perioperative blood pressure measurement. So we did pre, intra, post and the physiology, which all turned out to be very, very popular. They're all open source via the British Journal of Anaesthesia. Now, one of the big discussion points in that was this threshold of a MAP of 65. There's a lot of emphasis being placed on that now. And at the meeting, there was a lot of support for the MAP of 65, which came out of large data sets. But one of the questions was those data sets were dominated by a single organisation. So they were dominated by great work coming out of the Cleveland Clinic on lots of patients. But the question always was, will that stand up if you look at a broader sweep? And at the EBPOM meeting in London this year, you had a paper, one of your fellows presented, that it does seem as though that number stands up.
That's exactly right. Yeah, of course. So you're absolutely right. Dan Sessler's group at the Cleveland Clinic has led the charge in this space. They've published their own data from the clinic, demonstrating exactly what you say, that a MAP of 65 for a varying period of time is associated with adverse outcomes, by which I mean death, readmission, MI, stroke, acute kidney injury, with an odds ratio of in the 20 to 25% sort of range. But the problem is it's a single centre. So our idea was to say, let's find a different data source and let's do a similar analysis but not include the Sessler group. Specifically because, as you know, one of the fundamental tenets in good science is independent replication and validation. And I felt, and I'm sure Dan was a bit upset at the time, but I felt very strongly that if we can reproduce that work completely independently, it will validate that finding and that concept, specifically in something as important as blood pressure, perhaps our most easily but infrequently modified risk factor for adverse outcomes. So we went to the Optum dataset, which is a large EMR-based data repository that from around about 2,000 hospitals, 7,000 clinics, and it's got administrative code data in, it's got fluid data, it's got medications, it's got lab values.
You said US-based.
It's US-based, yeah. And it's fairly reasonably spread across the country, the USA. There are a few geographical aberrations, notably on the West Coast, as I believe. Anyway, the point is that we asked the question in non-cardiac surgery, is there an association between intraoperative, the first paper, and the second paper is postoperative blood pressure control and adverse outcomes? And so to cut along, so both of these papers are currently under review in the literature. The first paper focused on intraoperative blood pressure control, has 370,000 patients was the final surgical cohort. Spread
How many institutions? You can probably.
So the Optum data set has 2,000 hospitals in. So more than one, which we thought was important. And I have to say, and I still don't know if the Cleveland Clinic is in that data set or not, but if it is, there are 1,999 other ones as well.
Yeah.
So we excluded people for whom we didn't have reliable data. We excluded anybody having a caesarean section, because that's an entirely different, extremely important, but a different surgical procedure, especially from a blood pressure control perspective. We excluded people who we didn't have a touch point in the year before or the year afterwards, because we wanted good baseline comorbidity information and then follow-up. Anybody who had a general surgical operation within 3 days of a heart operation we excluded, and then various other things that basically talk about data integrity and whether or not we had enough information to draw any conclusions. So we had 370,000 patients in the final cohort. And we examine the incidence of hypotension using 5 different definitions, which will all be in the paper. And for reasons I'll come on to in a minute, it doesn't really matter how you measure or approach hypotension. The findings were remarkably consistent. And then we controlled for demographic issues: age, gender, hospital type, location, extent of comorbid disease, and so on and so forth. And then measured the association of blood pressure control in the operating room with subsequent outcomes. And so just in the operating room, the long and the short of it is there is no safe blood pressure below 75 millimeters of mercury.
75.
Yeah. The risk seems to start at 75. MAP of 75. The MAP really, the index, the odds ratio really takes off at 65.
Okay.
As we've long thought. And the odds ratios for major adverse cardiac and cerebral events for 65 is 1.17, so a 17% increase in that. We think most people would agree that MI, stroke and death are important clinical outcomes.
So just to pause for a second, the threshold that we eventually published in the paper, in our POCI guidelines, was 60 to 70.
Right.
I think you're saying there's no need for us to rewrite that at the moment.
No, absolutely. I think the risk begins at 75, really takes off at 65, and by the time you're significantly below a MAP of 55, that's when the risk starts to reach the 25, 30, 35%.
The need to control hypotension is clear. Here, Monty speaks with Thomas Scheeren, Chair of the Cardiovascular Dynamics Section of the European Society of Intensive Care Medicine. They're speaking about the HPI Monitor.
Okay, so how did they develop that technology? This is the bit that they call the machine learning, artificial intelligence sort of idea.
They took historical data from patients, from intensive care patients, but also from the OR setting, and they looked at the arterial waveform very, very narrowly. So they divided the arterial waveform into different parts and looked very precisely at these multiple millions of waveforms that they collected in those patients, and they fed the machine learning algorithm and developed an algorithm, the best predictive model, which can predict based on these waveform features when a hypotensive event will occur within the next minutes.
And there's a threshold that's been agreed where it reaches a number, I think, of 85, this HPI. Right. And above that, there's a colour change in the indicator, and effectively there's an alarm. It says, now's the time to really concentrate because it looks like hypotension is going to happen soon.
Yes. And the nice thing is at the same time you have the opportunity to look at a secondary screen at the monitor, which gives you some hints which might be the origin for the hypertension, because hypertension, there are different types of hypertension and different origins of hypertension which need a specific treatment. So this secondary screen might help you to define which is the cause of hypertension in your particular patient so that you can choose the right therapy.
This is at the moment is a specific Edwards Life Sciences technology approved by the regulators, which is available via the Edwards platform of hemodynamic monitoring.
Right.
So if the number goes to a particular level, you go to this so-called secondary screen and it says it looks like it's probably a preload problem, volume. Right. It looks like it might be contractility of the heart. It looks like it might be afterload. So maybe it's volume, maybe it's an inotrope, maybe it's a vasopressor.
Right.
So how does it work in practice? Is it something an experienced practitioner would need? Mike Spiro, anaesthetic consultant at the Royal Free Hospital.
So when we were asked to trial this upgraded software, it seemed like quite an exciting opportunity, even though I have to say I was extremely sceptical. I was told that this device would give us 5 to 15 minutes of warning before a hypotensive event, and I thought, given that in the major HBB patients we've got a complex patient having complex surgery and a variable anaesthetist in myself, how can a machine predict something that we can't see when looking at an arterial line? Anyway, I played with it a little bit in theatre, and I have to say it made me quite uncomfortable the first time I used it. I had a beautiful screen, beautiful chart, yet I was still being told the patient's chance of hypotension was 90%. And it made me very anxious, and I couldn't play with my iPhone quite as much as normal. And yet, when it told me that the hypotension was coming, even though my art line looked lovely and I couldn't see much swing and everything else, it did actually happen, and that made me feel even more uncomfortable in my clinical ability.
This clip is taken from a piece, EPOM 2018, Hypotension Probability in Practice, where Mike and Jez Fabes, Speciality Register and Academic Clinical Fellow of Anaesthesia at the University College London Hospitals, explain how they used the HPI Monitor to conduct further research. The full presentation is available in the TopMedTalk archives.
So what can we conclude from this? I think we've shown that HPI outperforms the current indices for predicting hemodynamic instability, so stroke volume variation, pulse pressure variation, with a good negative predictive value. The positive predictive value depends very much on how you analyse the data and the methodology behind that. And I don't think there's a right or a wrong way, there's just different ways to do it. There's a very good association with hypotensive risk, but no association with the severity of that subsequent hypotension. And as you get closer to the hypotensive event, the HPI reading is more effective at predicting that. We think it's acceptable to use that algorithm at a map target of 70, but probably less useful at 60 as the positive predictive value was just so low.
The Hypotension Prediction Index takes 2.6 million features from a single waveform, which it then applies to 150 million different waveforms, looking for factors that can predict hypotension. It's the first fully approved foray into predictive analytics for the world of anaesthesia. Here, one of the developers gives us his take. Ferris Hatib, Director of the Research and Development, Algorithms and Signal Processing at Edwards Life Sciences.
And what is it that the machine can do that we can't see?
Yes, so basically HPI tries to detect the failure of the compensatory mechanisms that maintain blood pressure stable. So to maintain blood pressure stable, physiologically there is a contrabalance between preload, afterload and contractility, right, that contrabalance each other to maintain blood pressure stable, and that those contrabalance mechanisms create very complex relationships and dynamic links and physiological associations between different physiological or cardiovascular variables. So the HPI algorithm takes the arterial pressure waveform and measures, out of the arterial pressure waveform, measures parameters related to preload, to afterload, to contractility, to aortic impedance, etc. And then detects, with machine learning, with artificial intelligence techniques, detects those complex multidimensional associations between all these hemodynamic variables to detect early failure in the compensatory mechanisms that lead to hypotension. So this is basically the high-level algorithm description.
Sol Aronson now, tenured professor at Duke University, presenting on TopMedTalk with Desiree Chappell, and their guest, Neil Fleming, professor, anaesthesiology and pain medicine at UC Davis.
It's like, how do you use it? If you could describe your user case, scenario, walk us through a day in the OR.
So most of what I'm doing in the OR, I have the privilege of, I'm usually working with a resident or a CRNA. More times than not, it's going to be either a major vascular or thoracic case. So during the course of that, I'm trying to figure out how am I going to take care of the patient, and then also what am I going to teach the resident or the nurse in terms of general education. So I pretty consistently have a two-pronged set of priorities, and so if we're doing a case that makes sense, a major vascular case, we're going to do intra-arterial monitoring. We'll spend a fair chunk of time talking about options for monitoring and stuff like that. And these days I will pretty routinely pull in an HPI system, and we'll talk about kind of how it's working, what it's telling us. And it's a wonderful opportunity basically to relive physiology.
Yeah. How has it changed your practice?
The key thing is that it extends the therapeutic options beyond just giving more volume, provides additional guidance, and frankly gets you working towards a solution before the problem occurs pretty consistently. The ease of use is it's a different pressure transducer plugging into a monitor with appropriate software. To be honest though, in terms of ease of use, it presents some relatively complicated, it's a lot more information.
Yeah, it's more information.
It's a lot more information.
How do you filter? How do you build your own internal algorithms to practice in a pragmatic way, given that bolus of data information?
I think it's important, at least with something like this that comes in with so many new things, is to make sure you have a good foundation. So in our institution, we were pretty early adopters of the whole concepts of dynamic monitors as guide to fluid management and arterial pressure-based measurement of cardiac output, and using things like stroke volume variation to guide intraoperative fluid management, and trusting the cardiac output numbers that you get from arterial pressure monitoring. So you need that foundation first. And I don't know where things are for you guys in that whole world, but I think that's a key starting point. And unless you do that, you can't run. Yeah. That's the walking part. Because the first thing you do when you bring... This one's different because it's more advanced and it's a little more complicated. And when you first drop it in the OR, folks are a little bit... Well, they're scared that they're angry a little bit.
Why are you bringing this something in here?
Like, I don't need
taking away my ability
making
to
this
make
hard.
decisions.
I used to have an expression. I'm an old guy. Back when I was younger and taller, I used to have an expression that there's an adaptation rule. I used to call it the 300-second rule. That if you bring a new thing, technique, tool, device into a setting where you have a routine baked into your daily schedule, and it takes more than 300 seconds to adopt that into your already established flow, it's likely not going to happen. Now, I'll modify that to between data and change is reality. And so unless there's an emotional tug to accept a 300-second threshold that is, not sufficient, it is hard. And so speaking to the change management subject, if we understand that the downstream consequence of our efforts upstream are meaningful and impactful, then we're willing to invest in that upstream process.
For this one in particular, you drop it in, there's a huge denial piece of it.
Yeah.
Because
I don't need it.
I don't have a problem.
Exactly.
He's got a problem with hypotension, but mine don't.
Yeah.
Never. Yeah. And so there's the whole will it work that you have to get through. You have to demonstrate that it actually does work, and that takes longer. That takes not 300 seconds. That probably takes half dozen cases.
Yeah.
And then you got to say,
We just heard from Dr. Andy Shaw a few hours ago about some work that he has done in a retrospective data analysis, a very, very large data set. But what the take-home buzz was, nearly 20-25% of our patients are hypotensive by definition.
Yeah.
And so this is an endemic. This is a major moment of revelation.
Well, because I think in the past we've they're protected by the anesthesia, right? Because they don't need as much blood pressure when they're anesthetized. That's what we've been
told.
So you have to get over that piece of it. So there's that huge component to it.
Don't forget, of course, the fuller conversations are available in the show notes. So, how effective is this process at not just predicting hypertension, but also controlling it? Desiree Chappell with her guest, Marit Habischer, specialist at UK GM Gießen.
Had the opportunity to test that device 2 years ago, and just thought we want to know if it really works in the clinical practice, if we can really prevent hypertension. Not only to show that hypertension will occur, so we wanted to know if a go-directed therapy using an HPI monitor can prevent the hypertension. So we had a really small study, but it was a pilot trial where we had a historical control group, we had a blinded group, so we had 25 patients where we measured the HPI, but the anesthesiologist could not see that. And we had the intervention group where we where we measured the HPI and had a protocol using the HPI to prevent the hypertension. So we had the three different points. We had the preload, the contractility, and the afterload. And whenever something is going wrong and the HPI was about 80, then we had to treat that. So we wanted to prevent that the patient really gets into a hypertensive episode. And that was...
Let me ask you, so just taking it back just a little bit, So you guys were already utilizing advanced hemodynamic monitoring in practice, right?
Yes.
And what type of patients were you using?
Orthopedic patients. It was hip prothesis patients, primary hip prothesis.
Primaries, okay.
So the most patients were between 60 and 67 years old, and so with the with the medium risk. So
that's what I was going to ask. The risk stratification.
Yeah,
that you
it's a
were
medium
using.
risk patient.
Okay. And is that were you using it for? Were you using like GDT or goal-directed therapy for any other patients? Had that kind of spread into any other service lines?
Normally, we use the goal-directed, especially in high-risk patients.
Yes.
So, but we wanted to know if a medium-risk patient it will work either. So we tried to use it in medium risk. And my previous work was also on medium-risk orthopedic patients, where we used the goal-directed therapy using another hemodynamic monitoring. There we could show that we can reduce complications if you use goal-directed therapy. And so we tried to make the new study with the HPI either in the medium-risk patients. So
okay. And what did you find? What were?
Yeah, well, it was interesting how other speakers also said that normally if you are experienced in anesthesia, you think you will see when the patient is getting bad and the hypertension will occur. But it was all in our study either that the historical control group also the blinded group had in medium 10 minutes during the operation with a hypotensive episode, so the total duration. So it was something about 6 to 7% of the operation time. The patient was with a mean arterial pressure lower than 65.
65,
so
okay.
it was the same. Yeah.
And that's what Thomas actually had found in his research.
It was the same results in our study, and we could reduce the total duration in medium to 0 minutes. So of course, there are some patients who are have 2 or 3 minutes, but in the medium duration was 0 minutes with the HPI group. So our protocol seems to work. And
So tell me, how many patients was this study? You said it was a small pilot.
Small.
Which
so
is fine.
was the HPI group was 25. So the blinded control group was 25, and the historical group were 50.
Gotcha.
So regarding that was a pilot trial, we did not find any other outcome benefits regarding length of stay or complications, but it was not the aim of the study. The aim of the study just was to show if we could reduce the frequency of hypertensive episodes and if we could reduce the duration of the hypertension.
So, where next? In this final clip, Monty Mython speaks in this order with Maxime Cannison, Professor of Anesthesiology and Vice Chair for Perioperative Medicine at UCLA Health, Thomas Scheeren, Professor of Anesthesiology, University Medical Center, Groningen, and Chair of the Cardiovascular Dynamics Section at the European Society of Intensive Care Medicine, with also Bart Geers, Consultant Anaesthetist at Amsterdam UMC.
And so the long-term vision of these two concepts is to merge predictive analytics together with closed-loop systems. So that's something that may sound a little bit like science fiction to some, but when I look back 5 years ago, it was really science fiction. People would try to understand what is going to be the value proposition of this system. And I think today we've made some progress and we've seen some applications of this concept.
And have you done it both with fluids to address the volume issue, but also cardioactive drugs? Have you gone that far as well? Or have investigators gone?
So with the fluid management, we've developed a closed-loop system that now has been developed by Edwards Life Science that led to a very first iteration of this closed-loop system. That's the AFM, the Assisted Fluid Management System. That's an open-loop system. With vasopressor, we are in the early stages of development of a closed-loop system that would deliver any kind of vasopressor drug and would maintain blood pressure within narrow ranges. So that's something we've done a lot of in silico studies in computers. And we've done some animal studies that are about to be published, hopefully pretty soon. And then we've also done some human studies in Europe. when we develop system for fluid management or for vasopressor administration, we try to be drug agnostic, that the system gives whatever fluid the clinician chooses. We don't interact with the goal of the clinician in terms of hemodynamic management. We don't choose what should be the blood pressure target or what should be the cardiac output target for the patient. We let clinicians choose this. The same way we let clinicians choose the drug they want to use to administer to their patient, because we believe that this is the medical strategy and the clinician should be in charge of it. But what we ask the system is to serve the clinician, is that once the clinician choose the drug and choose the target, the system is here to assist the clinician in delivering this medical strategy.
We talked before about the fact that it sounds to me a little bit like if you're a sailor, for example, that you sometimes ask the autopilot equivalent to keep the boat on track while you go and attend to something, make a cup of coffee or go to the loo or whatever it is. But for very many sailors, apart from very high-level helms, the autopilot's usually slightly better than the human. Is that what you think will happen here as well?
Well, so I like the analogy with the sailor in the sense that you have an autopilot that puts you on target and that keeps the cap, right? But you also have the weather forecast for the sailor that's going to tell you what's going to happen next day, and then the sailor in charge changes the direction sometimes to bypass an obstacle, right? Is it better than the actual sailor? I actually don't think that automation and predictive analytics do better than expert clinician.
Yes.
I actually believe that an expert clinician who spends a lot of time focusing on the patient is going to do as good as the automation. I think these kind of concepts are going to elevate the ability of trainees or mid-level provider to do a job that's going to be as good, as accurate as an expert clinician. And if you look at the big picture, if you're able to take people who are just out of residency or still in training and you make them perform at the level of an expert clinician, the expert clinician may be upset. So that's where we are going to get the pushback, right, to some extent.
Yes.
But overall, it makes the care better for a whole patient population. So I don't think this system do better than experts. On the long run, they may, because just the fact that the vigilance of the system is higher than the vigilance of a human being. But what they do is that they augment the ability of a trainee or mid-level provider to deliver care as good as the expert.
But even the greatest experts sometimes have to put their attention towards something else, go and draw a drug up or go look around the patient. And Thomas, where do you see all this going? Do you think it's an inevitable part of the future, or...?
I certainly do. I have no personal experience with those systems, but I'm an associate editor of the Journal of Clinical Monitoring and Computing, which sees a lot of these papers coming using this technology, and it sounds very exciting. So I'm very sure that it will make it to the market and will be adopted by the clinicians very soon. Do
you think we'll go straight to closed loop, or do you think we'll go via the passage of advice, decision support, and then semi-closed, and that's the journey? Because it's regulatory, it's a complicated regulatory area.
So I would dare no prognosis what the regulatory authorities will think about it, because they have their problems with these decision support systems usually. But if these problems are solved, I think why not directly go to a closed loop approach?
Because in discussion about it, there's two ways of interpreting it. You can either, the machine can be making the decisions, if you see what I mean, or the machine can be supporting you to make your decisions.
Exactly.
But so you're the owner, as Maxime was referred to. You remain the owner of your decision.
Exactly. So the doctor should have the last word in confirming the decision of the machine and or approving it or disapproving it, if necessary.
Bart, thoughts on this?
Well, I think if you look at radiologists, they've had to work with AI a bit longer than we are used to now, I think, because images are more standardized.
Yes.
What I see there is that there's consequent data coming out looking at mammograms that radiologists and the AI working together actually outperform both apart.
Yes.
So I think I really would say that if you get these systems into our clinical practice in ICU or anesthesia or emergency department, you'll see that they will join up. That's what I think.
Any concerns you have?
Well, of course, there's also the factor of de-skilling.
Yep.
So you'll probably have these trainees, they start leaning on this tool. What can they work without eventually? And do they still get the full experience? So ultimately, will they perform less than the AI? We don't know. But that's something that I would look out for.
I'd like to follow up on this one, because I think that's an issue that you see with any kind of technology, not only medical technology. But if you take a device as simple as the pulse oximeter, before the pulse oximeter, it would take a trainee months and months of clinical training to identify and diagnose accurately cyanosis in a patient in the ICU or in the operating room. When the pulse ox came up, suddenly you just had to tell the trainee that when the SpO2 is less than 90% and the SpO2 waveform is okay, your patient has cyanosis. And then within 5 minutes, a trainee would learn how to detect cyanosis in their patient. And it's true that today all of us, we rely heavily on the SpO2 waveform and the SpO2 number, and we are probably not as good as our mentors to detect cyanosis, but at the end of the day, it makes anesthesia safer. We are moving the expertise, but we still have challenges to solve in the future.
Bart Gears there with his thoughts on the future. Thanks for listening to TopMedTalk. If you enjoyed this programme, don't forget to check out the show notes where you'll find links to all of these conversations in full as part of the TopMedTalk archive.
TopMedTalk.
Thanks for downloading TopMedTalk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn and YouTube. And also, don't forget, TopMedTalk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.